Welcome back to the deep dive.
It's great to be here.
Today we're undertaking a mission to really zero in on a single disease that has, well, just devastating global consequences. But, and this is the really incredible part of the story, its modern management is also one of the greatest success stories in clinical medicine.
It absolutely is. We're talking about diabetic retinopathy, or DR for short.
And the stakes, as you said before we started, they just couldn't be higher.
No, they couldn't. For a long time, this condition was the single most common cause of new blindness in working-age adults.
In most industrialized countries, right?
Across the board, it hits people right in their prime, their most productive years, which makes the socioeconomic impact just enormous.
And if you look back, say, just a few decades, the outlook was, frankly, pretty grim. A diagnosis of advanced DR meant a very, very high chance of severe, irreversible vision loss.
That's the crucial context. Our deep dive today is really designed to do two things. First, to synthesize the foundational pathology, to really get into exactly how chronic high blood sugar attacks the eye's delicate structures.
Okay.
And then second, to track the monumental shift that came from landmark research. I'm talking about things like the early treatment diabetic retinopathy study, the ETDRS,
A huge one.
and the subsequent anti-VEGF trials, which just changed everything.
It really feels like a narrative of damage control. You mentioned a stat that I find staggering, that with effective screening and modern treatments, the risk of severe visual loss today can be cut to less than 5%.
Less than 5%. That reduction is the triumph we want to unpack. It's not just, an improvement. It's a near total reversal of historical fortune for millions of people.
So our mission for you, the listener, is to get a comprehensive handle on both the mechanisms of destruction and the incredible tools that were developed to fight back.
Exactly. And to really appreciate how the system breaks down, we have to start by understanding how this incredibly intricate system is supposed to work in the first place.
Okay, let's build the foundation. Let's unpack the architecture of the retina. The circulation here it's unique in the body, isn't it?
It is, mainly because it's supplying the most metabolically active tissue we have, the retina, which is essentially, external brain tissue.
So let's start with the inflow, the central retinal artery. What defines this structure?
The most important takeaway, the thing you have to remember, is that the central retinal artery is an end artery.
An end artery. What does that mean in practical terms?
It means there is virtually no backup, no collateral circulation. It enters the optic nerve sheath about a centimeter behind the globe, and from there, it's on its own.
So if it gets blocked?
The tissue it supplies dies almost instantly. There's no alternate route for the blood to get there. The system has no redundancy.
Wow. Okay, that immediately raises the stakes. So let's look at the wall of that artery itself. It has 3 distinct layers.
Right. Starting from the inside, you have the intima. This is a single layer of endothelial cells, and they're the interface between the blood itself and the vessel wall.
And just outside of that?
Moving outward, you have the internal elastic lamina. Think of it as a separation zone. It provides structure, and it separates the intima from the thick, muscular middle layer, the media.
The media is made of smooth muscle, right? So that's what provides the ability to constrict and dilate to control blood flow.
Exactly. That's the functional control.
Yeah.
And then the outermost layer is the adventitia, which is just loose connective tissue that basically anchors the artery in place. It's a classic, robust arterial structure.
But as that main artery branches out across the retina, it quickly becomes a network of much smaller retinal arterioles. How does their structure change?
Well, they're smaller distribution vessels, so they still have smooth muscle on their walls for local pressure control. But the key difference is that internal elastic lamina becomes discontinuous, less defined.
A transition point.
It's a transition. It reflects that they're now just regulating flow right before we get to the final, most delicate zone, the microcirculation.
The capillaries. And this is where the first silent damage of diabetic retinopathy really happens.
This is ground zero.
Where is this network actually located within the retinal layers?
The retinal capillaries are the sole supply line for the inner 2/3 of the retina. That includes most of the neural components.
And the outer third, the photoreceptors.
They get their blood from a totally separate system, the choriocapillaris, which is a much larger high-flow system. For DR, our focus is almost entirely on that inner retinal supply from the retinal capillaries.
Okay. And these capillaries, they form networks or plexuses.
Exactly. 2 interconnected plexuses. There's an inner one in the ganglion cell layer and a deeper outer one in the inner nuclear layer. It's a very highly structured system built for efficiency.
And to function properly, the retina actually needs some areas to be clear of capillaries, which seems counterintuitive.
It does, but it's essential for clear vision. The most critical of these is the foveolovascular zone, or the FAZ,
The very center of our vision.
the absolute center, the
Yeah.
tiny area of the macula responsible for 20/20 vision. It has to be completely free of capillaries to allow light to strike the photoreceptors without any obstruction. Keeping the FAZ intact is everything for central vision.
So now let's zoom in even further on the capillary anatomy itself. This is the unit that's first compromised.
And it's fundamentally different from an artery. The capillaries have no smooth muscle, no elastic tissue. Their wall is just a single layer of endothelial cells,
Just one cell thick.
one cell thick, and this thin layer has to hold the line. It does that using very specific connections called tight junctions.
And those tight junctions, they're basically the entire defense system. They form the inner blood-retinal barrier.
They're absolutely vital. These junctions link the endothelial cells together like molecular mortar, creating barrier that strictly regulates what gets in and out of the bloodstream into the delicate retinal tissue.
So if those junctions fail,
The barrier breaks down, fluid starts to leak out, and that is the very beginning of retinal edema.
but there's another critical player here. The endothelial cells aren't alone. You have these crucial supporting cells, the parasites.
The parasites. This is where the story of diabetic retinopathy truly begins.
Tell us about them. What do they do?
They're fascinating cells. They sit on the outside of the endothelial cell, sort of wrapped around the capillary. Think of them as guardian cells, physically enveloping the vessel.
So they're not just for structural support.
No, they're active participants.
Mm.
They have contractile properties, so they help auto-regulate the blood flow and stabilize capillary pressure. And critically, they communicate with the endothelial cells to maintain those tight junctions and suppress abnormal vessel growth. They're the stabilizing element.
And if we connect this to the big picture of DR, the loss of these parasites, that's the first quantifiable sign of damage, isn't it?
It's the hallmark feature. Their preferential loss, which we sometimes call parasite ghost cells, signals the start of the entire pathological cascade. Once they're gone, the capillary wall is destabilized, which leads to microaneurysm formation, loss of autoregulation, and then the breakdown of the blood-retinal barrier.
Leakage, inflammation, the whole thing starts right there.
That's the transition from a functional system to a pathological one.
Okay, let's quickly round out the foundation with the outflow system, the venules and veins.
The flow starts in small venules, which are structurally very similar to capillaries at first. As they merge, they form larger collecting venules that start to acquire a little bit of smooth muscle.
And then finally into the large veins.
Yes, which are built for volume. They're relatively distensible, designed to collect all that deoxygenated blood and carry it back to the central retinal vein. They handle pressure changes well, but as we'll see, they're very sensitive to what's happening upstream, to capillary blockage.
Which leads to visible changes like venous beating. So we've built the pristine system. Now, let's talk about the disease that relentlessly compromises it. Diabetic retinopathy. Let's start with the sheer numbers. How big is this problem?
The numbers are pretty sobering. The reported prevalence of DR in people with diabetes is around 40% globally. But the really alarming part is that a huge number of those patients, sometimes up to half, have no idea they have it.
Because it's asymptomatic in the early stages?
Completely asymptomatic, which is why screening is so vital.
Is there a different risk profile for type 1 versus type 2 diabetes?
Yes, there is, although both are heavily affected. Statistically, DR is more common overall in type 1 diabetes. This is mainly because type 1 often has an earlier onset, so patients just have a much longer duration of the disease, allowing all that cumulative damage to build up.
And type 2.
In type 2, the onset can be more insidious, but the prevalence is still incredibly high. Studies show 67% of patients have some form of DR 10 years after their diagnosis, and of those, 10% will progress to the most severe stage, proliferative diabetic retinopathy.
Wow. Okay, that sets the stage. Let's move to the primary drivers. If you had to identify the single biggest, most important predictor for this disease, what would it be?
Oh, hands down, it's the duration of diabetes. That is the undisputed champion of risk factors.
More than blood sugar control.
In terms of prediction, yes. DR is incredibly rare within the first 5 years of onset, or before a patient hits puberty, no matter how poor their control is. This tells us it's a cumulative disease. It takes years of exposure to that metabolic dysfunction for the damage to show up.
And duration even predicts the type of damage we see, right?
It does. Duration is actually a stronger predictor for the advanced proliferative disease. the new vessel growth, than it is for maculopathy, which can sometimes appear a bit earlier. The longer you have diabetes, the greater the chance of that widespread ischemia that leads to PDR.
Okay. Next up is the obvious one, glycemic control. Landmark trials, DCCT, UKPDS, they prove that tight control works. But there's a surprising detail in there, a paradox.
Yes, the paradox of rapid control. This is a critical nuance for everyone to understand. While long-term, rigorous control is the ultimate defense, a sudden or overly rapid improvement in blood sugar can, paradoxically, be associated with a temporary worsening of the retinopathy.
Why on earth does that happen? Is it like a shock to the system?
That's a good way to think about it. The precise mechanism is complex, but one theory is that the sudden change in the metabolic environment alters retinal blood flow and oxygen delivery. It might even cause a transient inflammatory state as the vessels struggle to adapt.
So if a patient starts on insulin for the first time and really gets their numbers down fast,
They need closer surveillance for a little while. The progression is usually temporary, and the long-term benefits of tight control still vastly outweigh this short-term risk, but it's something we have to monitor carefully.
beyond glucose, there are other systemic factors. This really is a case where the eye is a barometer for overall health. Let's talk hypertension.
Hypertension is a massive comorbidity, especially in type 2 diabetes. High blood pressure just compounds the stress on those already vulnerable retinal capillaries.
So the recommendation is?
Rigorous control, ideally blood pressure below 140/80. Tightly controlled blood pressure is proven to be particularly helpful in preventing and treating maculopathy, the part that threatens your central vision.
And what about kidney health? Diabetic nephropathy.
They are very closely linked. They share common pathways of microvascular damage. So severe kidney disease is strongly associated with worsening DOCR. Conversely, if you can fix the kidney problem, say, with a successful renal transplant, you can actually see a measurable improvement in the retinopathy.
And the last of the big three systemic factors, hyperlipidemia.
Right. Elevated blood lipids are a known risk factor. They often contribute directly to the severity and density of hard exudates, which we'll get to in a minute. So managing lipids is crucial.
We also have these unique sort of temporary risk factors, the big one being pregnancy.
Pregnancy can dramatically accelerate DR. It's a perfect storm of factors. Massive hormonal shifts, increased blood volume, and often a very sudden attempt to get blood sugar under tight control.
What kind of risk are we talking about?
The risk of progressing from moderate DR to the dangerous proliferative stage during a pregnancy is about 1/3. That is a huge short-term jump in risk. It means we have to see these patients much more frequently, sometimes every couple of weeks.
Are there any specific medications that can complicate DR management?
Yes, the main one to watch for is pioglitazone. It's in a class of drugs called thiazolidinediones, and it's specifically associated with a risk of worsening diabetic macular edema, or DMO.
Why is that?
It's thought to be due to its effect on fluid retention. If a patient on pioglitazone develops or has worsening DMO, we often have to stop the medication.
Okay, so let's tie this all together. Let's nail down the ultimate mechanism, the pathogenesis. What is diabetic retinopathy fundamentally?
Fundamentally, DR is a generalized microangiopathy. It's a disease where the small vessels, the capillaries and arterioles, are uniquely vulnerable to damage from chronically high glucose.
And that damage starts with those structural failures we talked about.
Exactly. The loss of parasites, the thickening of the basement membrane, the breakdown of the tight junctions.
Which leads to ischemia, a lack of oxygen, and the body's emergency response to that is where things get really bad.
That's the cascade. The body frantically tries to compensate for the poor oxygenation by overproducing chemicals that tell it to grow new blood vessels. We call them angiogenic stimulators.
And the main villain in this story, the primary target of our modern therapies, is one of those stimulators.
It is. It's called vascular endothelial growth factor, or VEGF.
VEGF.
VEGF is the crucial molecule. It's responsible for driving almost all the bad things that follow. It makes vessels leaky, causing edema, and it drives the creation of those fragile, abnormal new blood vessels that define the proliferative stage. Understanding VEGF is the key to understanding modern treatment.
So to make sense of this progression from leaky to ischemic to proliferative, we need a framework. And the one everyone uses is the ETDRS classification.
Right. The early treatment diabetic retinopathy study gave us the modified Early-House classification. It's the common language of diabetic eye care worldwide. It lets us move from just describing what we see to objectively quantifying the risk.
It all starts with the mildest signs, known collectively as background diabetic retinopathy, or BDR. And the signature calling card of BDR is the microaneurysm.
Microaneurysms are the earliest visible clinical signs. They are these localized saccular outpouchings of the capillary wall, and they form almost exclusively where parasites are absent.
So there's that parasite-loss connection coming full circle.
Exactly. It's just a focal point of weakness in the capillary wall that bulges out.
And what trouble do these tiny aneurysms cause?
Two things. First, they leak. A lot. The tight junctions have failed, so they leak plasma and fluid into the retina, which causes edema. Second, they can thrombose or clot off. Clinically, they just look like tiny red dots.
Yeah. How do you tell the difference between a microaneurysm and just a tiny hemorrhage?
That's where imaging helps, specifically fluorescein angiography, or FA. An active leaking microaneurysm will light up brightly as it fills with dye, and then you'll see the dye leaking out into the surrounding tissue. A hemorrhage will just block the light. It'll look like a dark spot.
Okay, let's move to hemorrhages themselves. There are two main types, right? Based on shape and location.
Correct. First, you have the superficial ones.
Yeah.
The nerve fiber layer hemorrhages. Because they're in that layer, which is structured like a set of horizontal wires, the blood spreads along the axons. This gives them that classic flame or splinter shape.
And the deeper ones look completely different.
Yes, the intraretinal hemorrhages. They come from the venous end of the capillaries and are located in the more compact middle layers of the retina.
Yeah.
The tissue there is tightly packed so the blood can't spread, and it forms these dot or blot shapes.
And the number of those is actually a more significant marker for progression.
A much more significant marker than the superficial flame hemorrhages, yes.
Another clear sign of chronic leakage is the exudate, these waxy yellow lesions. What are they made of?
They're essentially the solidified leftovers of chronic edema. They're composed of lipoprotein and lipid-filled macrophages. They leak out of the microaneurysms and then settle in the outer plexiform layer. You often see them in a ring around a cluster of leaking microaneurysms.
And if a patient has poorly controlled lipids, hyperlipidemia, does that make the exudates worse?
Absolutely. It directly increases their likelihood and density. The good news, though, is that exudates are reversible. Once you stop the underlying leakage with laser or an injection, they will slowly absorb over many months.
Okay, so we've covered the background signs, mild to moderate NPDR. Now we get to preproliferative diabetic retinopathy, or PPDR. This is the big warning sign that ischemia is intensifying.
This is the warning stage. It's defined by specific signs that tell us the retina is starving for oxygen. The first key sign is the cotton wool spot.
Describe what that looks like.
It's a small, fluffy, whitish lesion on the surface of the retina. Physiologically, it's a microinfarct. It's what happens when a tiny retinal arteriole gets blocked. The nerve axons in that area get ischemic and swell up with debris.
And on that fluorescein angiogram, it would show up as a dark patch.
Exactly. A dark patch of hypofluorescence because there's no blood flow to that area. It's a clear sign of local ischemia.
Next, we have crucial changes in the venous system.
Right. As the capillaries get blocked up, the veins upstream start to react. We look for generalized dilatation, tortuosity, looping, and most critically, venous beading. It's where the vein develops focal narrowing and dilatation, so it looks like a string of sausages. The extent of beading correlates extremely well with the likelihood of progressing to PDR. It's one of our most reliable prognostic signs.
And finally, the one that can be confused with new vessel growth, intraretinal microvascular abnormalities, or IRMA.
IRMA. It's a key distinction to make. IRMA are essentially shunt vessels. They are new, widened channels that run from arterioles directly to venules, bypassing the capillary beds that have shut down from ischemia.
So how do you tell the difference between IRMA and true neovascularization, or NV?
Three key things. First, IRMA are always contained within the retina. Second, they do not breach the internal limiting membrane, the layer separating the retina from the vitreous. And third, and most importantly on an angiogram, IRMA do not leak. True new vessels leak profusely.
So those signs, cotton wool spots, venous beading, IRMAs, they're the components that tell us we've progressed to severe NPDR. And this stage has a specific alarming prognosis defined by the famous 4-2-1 rule.
Yes. The 4-2-1 rule is our definitive guidepost. It tells us when the risk skyrockets. Hitting these criteria for severe NPDR means there is up to a 50% chance of progressing to PDR within just 1 year.
Okay, let's walk through that rule. What are the three components?
You meet the criteria for severe NPDR if you have one or more of these. First, severe hemorrhages in all 4 quadrants.
So widespread damage.
Widespread. Second, significant venous beading in 2 or more quadrants.
Half the retina.
At least half.
Yeah.
Or third, moderate IRMA in one or more quadrants.
So hitting any one of those three puts you in the severe NPDR category.
Correct. And if you hit 2 or more, you're in very severe NPDR, and the risk is even higher. That means immediate action is needed.
Okay, let's shift focus to the other major threat to vision, which is right in the center. Diabetic maculopathy and diabetic macular edema, DMO.
DMO is the most common cause of moderate visual impairment, especially in type 2 diabetics. It's simply leakage from those microaneurysms that impacts the center of vision, the macula.
And again, the ETDRS gave us a very specific clinical definition for what constitutes clinically significant macular edema, or CSMO.
Right. These were the criteria that, before anti-VEGF, dictated when you had to treat with laser. There are 3 possibilities. 1, retinal thickening within 500 microns of the center of the macula.
Okay.
2, hard exudates within 500 microns of the center, but they have to have adjacent thickening. The exudates themselves aren't the main problem, it's the fluid.
And the third?
A large area of retinal thickening, 1 disc area or larger, that is at least partly within 1 disc diameter of the center.
And we also split DMO into a couple of different types, right? Focal versus diffuse.
Yes. Focal maculopathy is often easier to manage. It's a well-circumscribed area of thickening, often with those rings of exudates. The leakage is coming from specific individual microaneurysms that you can target.
And diffuse is the more challenging type.
Diffuse maculopathy is much more widespread. It's a generalized, spongy thickening of the retina, often with cystoid changes, these little fluid-filled pockets. The leakage is happening across entire capillary beds.
And then there's the most insidious type, where the macula looks almost fine, but the patient's vision is poor.
That's ischemic maculopathy. The patient has significantly reduced vision, but there's not much edema to see. The vision loss is permanent. An angiogram reveals the true problem: massive capillary non-perfusion at the fovea. The foveal vascular zone is enlarged and destroyed. The tissue is dead.
And no amount of treatment can bring that back.
Nothing can revive it.
Okay, that brings us to the next stage. We're moving now to proliferative diabetic retinopathy, PDR. This is where the body's frantic response becomes the primary threat.
PDR is defined by one critical feature: neovascularization, NV, the growth of new pathological blood vessels.
Driven by all that VEGF from the ischemic retina.
Exactly. And these vessels are terrible. They're fragile, they grow in the wrong places, they lack the proper structure, and they bleed easily.
Where do they usually pop up?
Most commonly at the posterior pole. We classify them based on their location. We call it NVD for new vessels on or within 1 disc diameter of the optic disc, and NVE for new vessels elsewhere, further out. NVD generally carries a higher risk.
Just having new vessels means you have PDR, but it becomes an acute problem when it hits the threshold for high-risk PDR.
High-risk PDR means the eye is on the verge of a catastrophe, a massive hemorrhage, or a retinal detachment. The criteria were established decades ago by the Diabetic Retinopathy study, the DRS, but they are still absolutely critical.
What are they? There are 3 main criteria. One is NVD that's greater than about 1/3 of the disc area.
Okay, it's a significant amount.
Yes. The other 2 involve bleeding. So any NVD that's associated with a vitreous or paretinal hemorrhage, or significant NVE that's associated with a vitreous or paretinal hemorrhage.
So it's a combination of new vessels plus bleeding that really defines the highest risk.
It signifies that the vessels are active, they're fragile, and they are already causing problems.
And progression beyond that leads to what we call advanced diabetic eye disease, the end stage.
Right, and the first major complication here is a significant hemorrhage. These fragile vessels can bleed into the vitreous cavity. It can be a paretinal hemorrhage, which is a pocket of blood just under the vitreous face, or an intragel hemorrhage, where it's mixed into the vitreous gel itself.
And the location matters for how quickly it clears?
Right, it does. Intragel hemorrhages can take months to clear because the blood is suspended in that thick gel. Paretinal hemorrhages can clear more quickly, but if it's dense enough, it blocks the view, prevents laser treatment, and makes surgery the only option.
And the worst mechanical complication is a tractional retinal detachment, or TRD.
This is the permanent vision-threatening endpoint. It's caused when the fibrous membranes that grow with the new vessels start to contract. They act like scar tissue, physically pulling the retina off the back wall of the eye.
And if that pull involves the macula.
Central vision is lost, and you have to perform surgery immediately.
And finally, a complication at the front of the eye that's driven by problems at the back. Rubiosis iridis.
Rubiosis iridis is the growth of new vessels on the iris. It's a desperate signal that the entire eye is severely ischemic and just drowning in VEGF.
And that can lead to a terrible form of glaucoma.
If those vessels grow over the eye's drainage angle, they block it, causing a severe, intractable rise in pressure. This is neovascular glaucoma, or
Yeah.
NVG. It's incredibly painful and often results in the complete loss of the eye.
It's a vicious escalating cycle. That brings us to Section 5, the fight back. How do we stop this cascade? We've laid out this severe progressive disease. Now we get to detail how modern medicine has managed to curb that risk of severe visual loss to under 5%. Where do we start?
We have to start with the foundation. General systemic management, patient education, compliance, and rigorous control of blood sugar, blood pressure, and lipids. We cannot treat the eye in a vacuum.
Let's focus on the lipids for a second. There's a specific drug that has shown an independent benefit for DR.
That's fenofibrate. Clinical trials have shown that it reduces the progression of DR in type 2 diabetics, and importantly, this benefit is independent of its cholesterol-lowering effect. So it helps even if the patient is already on a statin.
Okay, now for the major revolution, the treatment of DMO. For decades, it was all about laser. But then came intravitreal anti-VEGF agents.
And it was a true paradigm shift, a revolution. Anti-VEGF agents directly block the main pathological driver, VEGF. They reduce leakage and swelling far more effectively than laser ever could. They've completely replaced laser as the mainstay for center-involved DMO.
And this change was driven by evidence from the Diabetic Retinopathy Clinical Research Network, drcr.net.
Entirely.
What did their seminal Protocol I study show?
Protocol I definitively proved that ranibizumab, one of the first major anti-VEGF drugs, achieved a better visual acuity outcome than focal laser for center-involved DMO. It established a new standard of care.
Which was?
That laser treatment, if you use it at all, should be deferred for at least 6 months after you start anti-VEGF therapy. Let the injections do the heavy lifting first.
Then came Protocol T, which compared the heavy hitters, aflibercept, bevacizumab, and ranibizumab. What did we learn from that?
Protocol T was fascinating. It showed that for patients who started with pretty good vision, there was no significant difference in the final outcome between the 3 drugs at 5 years. They all worked well.
But there was a key difference for patients with worse vision.
A critical difference. Aflibercept showed superior efficacy when the patient started with worse vision 615 or worse. It was more likely to achieve a significant visual improvement in those really compromised eyes.
So that guides our choice of drug. If a patient comes in with severely reduced vision, you start with the most potent agent.
That's personalized medicine right there. It gives us a clear path.
And now we have a newer agent, faricimab, which is a dual neutralizer. It targets VEGF-A, but also something called angiopoietin-2. What does that add?
Angiopoietin-2 is a key regulator of vascular stability. So while VEGF promotes growth and leakage, Ang2 acts as a destabilizer. By blocking both, faricimab helps restore vascular equilibrium more comprehensively.
And the main practical benefit?
The dosing regimen. Studies showed it has comparable efficacy to the others, but it allows for a treat and extend approach that can stretch the dosing interval out to as long as 16 weeks for some patients.
That's huge for patient compliance.
It's a game changer. The biggest challenge with these treatments is the burden of frequent injections. The best drug is the one the patient actually receives consistently. Longer intervals make that much more achievable.
Anti-VEGF isn't the only injectable option, though. We still use steroids.
We do. Intravitreal steroids, like triamcinolone, or sustained-release implants like Ozurdex or Iluvien, are valuable alternatives. They're a good choice for eyes that haven't responded well to anti-VEGF.
And for specific patient populations.
Yes. They're considered a safer option for pregnant women who need treatment, or for patients who have a contraindication to anti-VEGF, like a recent heart attack or stroke.
But they come with their own set of risks.
A significant trade-off. There's a very real risk of causing high intraocular pressure, or IOP, which can lead to glaucoma, and they will accelerate cataract formation in almost every patient who still has their natural lens.
So what about laser? Has it been completely thrown out?
Not completely. For center-involved DMO, yes, it's not first line, but it still has a niche role for off-center retinal thickening, or when you have hard exudates that are threatening to crawl into the fovea. You can use focal laser to just zap the individual leaking microaneurysms.
And there's an experimental side to laser, too.
Right, subthreshold macular laser.
Mm.
The idea is to use very short, low-intensity laser pulses to stimulate the underlying tissue to pump out fluid, but without causing any visible damage. It's clever, but it still lacks the robust clinical trial evidence to prove it's better than our current treatments.
Okay, let's put this all together. Give us the treatment strategies for DMO based on current consensus.
Okay. For CSMO that does not involve the center, focal laser is still a primary option.
What if it does involve the center, but vision is still pretty good, better than 615?
Then you start with one of the major anti-VEGF agents, aflibercept, bevacizumab, faricimab, ranibizumab, on a treat and extend protocol.
And for the worst cases, center involved with vision at 615 or worse.
Based on Protocol T, the strong recommendation is to start with aflibercept or faricimab. You'd begin with monthly injections for the first few months to get the swelling down fast.
And if the DMO is persistent after, say, 6 months of anti-VEGF,
Then you have to change your strategy. You either consider adding laser to the mix or you switch to a steroid implant to target the inflammatory component that the anti-VEGF might not be fully addressing.
it's a very refined, customized approach. Now let's look at treatment for proliferative retinopathy, PDR. For decades, the gold standard was scatter laser.
Panretinal photocoagulation, or PRP. It's essentially a controlled sacrifice. You use thousands of laser burns to destroy the non-functional ischemic peripheral retina.
To stop it from producing VEGF.
Exactly. You sacrifice the periphery to save the center. The DRS trial proved its benefit, reducing the risk of severe visual loss from 26% down to just 9% in high-risk eyes.
A life-saving intervention. But it comes with significant trade-offs for the patient.
It does. We have to be clear about this. PRP causes permanent visual field defects. Patients lose peripheral vision. It can also reduce night vision and color vision. It's a harsh trade-off. Peripheral sight for central sight.
But now, just like with DMO, anti-VEGF is challenging PRP's dominance here too.
This is the newest frontier.
Uh-huh.
The DRCR.net Protocol S and the Clarity study had a stunning result. They showed that anti-VEGF monotherapy with ranibizumab, or aflibercept, was as effective as PRP in managing high-risk PDR over 5 years.
With a major advantage.
A huge advantage. The anti-VEGF group had significantly better visual field maintenance and lower rates of developing DMO compared to the laser group.
So if anti-VEGF is just as good and doesn't destroy the peripheral vision, why would anyone still choose PRP?
One word: compliance. Anti-VEGF therapy for PDR requires meticulous, frequent, long-term follow-up and repeated injections forever. If a patient is likely to be non-compliant or has poor access to care, a one-and-done PRP treatment provides permanent control. It's the safer bet when follow-up is in doubt.
What if a patient has both PDR and DMO at the same time?
The modern approach is to treat the edema first with anti-VEGF. This often causes the new vessels of the PDR to regress dramatically at the same time. Then you can decide if you still need to add PRP or if anti-VEGF alone is enough.
Finally, what happens when the disease is too advanced for just injections or laser, when surgery is required?
That's when we turn to a pars plana vitrectomy, or PPV. The visual outcome really depends on how much damage was already there, especially if the macula was already ischemic.
What are the main reasons to do this surgery?
The most common indication is a severe, persistent vitreous hemorrhage that's blocking the view and preventing you from applying PRP. You have to go in, clear out the blood, and do the laser from inside the eye.
And the other main indication is mechanical.
Yes. A progressive tractional retinal detachment, especially if it's threatening or involving the macula. That's a surgical emergency. You have to get in there and peel away those contracting membranes that are pulling the retina off. We also sometimes use it for a dense premacular hemorrhage to get it out of the way before it causes more scarring.
And there's a non-surgical laser trick for some of those hemorrhages, right?
There's a specific type, yes. A well-defined retrohyalate hemorrhage. You can use an ND.YAG laser to make a tiny hole in the membrane holding the blood back, a hyaloidotomy, which allows the blood to disperse into the vitreous and clear away much faster. It can sometimes avoid the need for a full surgery.
We started this deep dive by noting that DR is the leading cause of new blindness, but the knowledge we've gained has just shifted the needle dramatically.
It really has.
We've traced the journey from that initial microscopic damage, the loss of the parasites, all the way through the defined stages. The background leakage, the pre-proliferative ischemia with that critical 4-2-1 rule, the proliferative new vessel growth, and finally, the end-stage complications.
And we've tracked the management evolution right alongside it, moving from that destructive but necessary scatter laser to these sophisticated, injectable anti-VEGF agents that let us directly counteract the disease driver. All of it guided by the rigor of landmark clinical trials.
That reduction in risk, getting the severe visual loss rate below 5%, it's a true testament to clinical science. But here's the most important, maybe most challenging takeaway that connects everything we've discussed.
Oh,
While we have these incredible high-tech tools to treat the damage, the burden of compliance for these long-term treatments is immense.
it is. Therefore, tight control of the systemic factors, the hypertension, the hyperlipidemia, and of course the glucose, that remains the most powerful key, and it's the key to prevention,
Which is always better than treatment.
always. This deep dive should empower you to understand that ocular health isn't isolated. It's a direct, highly visible measure of your systemic health. Knowledge of these risks and mechanisms should compel all of us to prioritize that primary systemic control.
A perfect encapsulation of why understanding the disease is the most effective first step toward beating it. Thank you for joining us for this deep dive.
Always a pleasure.